Thank you very much for the invitation to come and speak to you. I've started just letting audiences know before I start that I do have a stutter, which sometimes impairs my fluency. I mention it because it sometimes makes people uncomfortable. I'll sometimes pause and people think I've either had a sudden fit of nerves and I'm terrified, or somebody has once been worried I'm having some kind of silent fit because I've paused. If a pause goes on for more than 5 seconds, maybe worry, but other than that, we're fine. So, and we're talking today about regulating risk in surgical innovation and giving a UK perspective. I'll be reporting the kind of ongoing work of a collaborative project we're doing between the Centre for Ethics in Medicine and the Centre for Surgical Research at the University of Bristol. We're funded by the National Institute for Health Research. Because we are government funded, I have to go through this disclaimer, so the views expressed now and those of myself and not necessarily those of the National Institute for Health Research or the Department of Health and Social Care. Acknowledgements, this is work that is collaborative, and I'm presenting kind of the product of an ongoing collaboration between myself, Giles Birchley, Jane Blaisby, Richard Huxtable, Teresa Swift, and the whole of the Bristol Biomedical Research Centre team. So the talk broadly represents our collective thinking, but with my own spin, and of course any mistakes are going to be my own. So I'm going to take you through a recent case in the UK of robotic-assisted heart surgery. I'll then briefly talk about the regulatory system in the UK, which is almost non-existent for surgery. And I'll then raise 3 key challenges that kind of come out of that case. And I'll look at the problem of defining innovation, the problem of consenting an unknown risk, and the problem of the surgeon's learning curve. And in each of those, I'll just start drawing out and pulling out points that lead me to draw a conclusion that we should take an eliminativist approach to regulating surgical innovation, but what I mean by that will become clear. So the case, first of all, this is the Da Vinci robot, and this is the case of Stephen Pettit, who is a 69-year-old retired music teacher. He underwent what's been described as pioneering robotic-assisted heart surgery using this robot in Newcastle Hospital's NHS Foundation Trust. Numerous problems occurred during this surgery. There was ambient noise from the robot which interfered with surgeon communication. The robot at one point knocked the theatre assistant's arm, and that led to disorderly stitches being made which needed replacing. And the patient then developed a bleed that blinded the camera on the robot. So by the time the surgical team decided we needed to go with open heart surgery, there'd already been irreparable damage to the heart tissue, and Mr. Pettit died. So the coroner said death occurred as a direct consequence of the operation and its complications. Mr. Pettit died due to complications of an operation to treat mitral valve disease, and in part because the operation was undertaken with robotic assistance. So death was a direct consequence of the chosen procedure. And some other factors. Mr. Nair, who was the surgeon, had observed the robot's use and practiced on a simulator by himself, but had declined one-on-one training. And he didn't tell the patient he would be the first person in the UK to undergo this robotic-assisted surgery, nor that it was the first time he had or would be performing it. So, the UK regulatory context is relatively easy to outline in the context of surgery, not drugs, not medicines. That's incredibly tightly regulated, but surgery, because in essence there really isn't regulation of new surgical innovation. Surgeons are, of course, bound by professional practice and professional responsibility. They can be found guilty of negligence or unprofessional practice, but there's no regulation that actually determines what they do. So a surgeon in the UK can use whatever technique they wish, whether there's an evidence base or not. They can just decide to make a change. This can range from minor modifications of an existing procedure through to completely newly invented procedures, although what counts as completely new is up for grabs, whether that's possible. And it can involve using either completely new or repurposed devices. And one of the problems with this setup is that a successful idea can often be reported at a conference. A surgeon tries it, reports it, colleagues think that sounds great, and suddenly it's adopted and used loads and loads and loads without an evidence base without testing. It also means that if a surgeon tries something and fails, they don't report it, which means that mistakes are not learned from. So Derek Olson, the chair of the Royal College of Surgeons, has noted recently, and in response partly to this robotic surgery death, in contrast to drugs, many surgical innovations introduced without clinical trial data or centrally held evidence, and this is a risk to patient safety and public confidence. So how could this death have been prevented? Well, the answer that's often mooted tends to be better regulation. And Gupta et al. Point out that the fragmentary and non-standardized oversight mechanisms leave surgeon innovators and patients open to significant risk of breaching the ethical principles at the core of surgical practice. A systemized approach that mitigates these risks while maintaining the independence and dignity of the surgical profession is necessary. So what might this look like? Well, Gupta et al. Have suggested this kind of framework. And what's interesting is it looks quite simple, it looks quite straightforward, but there's lots and lots of potentially problematic areas when we look at it a bit more closely. So first of all, and the question that we've started with in our project is, well, if the first step is to determine whether it's surgical research or procedural innovation, how do we know if we're doing surgical innovation? What is the definition? Second, it talks about risk, it talks about assessing risk, but once we've even assessed it, we also have to be able to communicate it. And it's in the nature of innovation, of something new, that we simply don't know what the risks are. And then another complication of surgery in particular is, even if the process itself is risky or non-risky, the risk profile changes depending on who's holding the scalpel, which complicates things even further. So we thought about, to start with, let's try and define surgical innovation. So in order to regulate something, you have to be able to define it. You have to be able to pick it out and say, this is the practice we're regulating. But it's not clear. So we started looking at possible definitions, and there's a range. So it's been described as a novel procedure, a significant modification of a standard technique, new application or indication, alternative combination of established techniques, etc., developed and tested for the first time. Or it could be anything that departs from standard surgical practice that's both non-validated and major. Or it could be a dynamic and continuous process involving the introduction of a new technology or technique that initiates a change in clinical practice. So they're not completely different, but they're not the same either, and there's problems with all of them. So if we look at the first one, well, this kind of definition simply defers the definitional problem. It switches innovation for new, significant modification. We have to know what new means, and defining newness is actually significantly harder. So for this definition to work, what's new? What counts as significant? What's a modification as opposed to a minor change? What's standard? What's established? And what's the first time? First time ever in the world, first time used by this pair of hands, first time used in this hospital, in this country. And then we have cases like a surgeon invents and uses a novel technique, genuinely, which unknown to them is already being used in another country by a surgical team they've not come across. That doesn't seem to satisfy something being developed and tested for the first time, so it wouldn't count as innovation. So we need to specify it further. Next, if we look at departures from standard practice, well, what's standard and what's major? If we, for example, decided to change the colour of surgical instruments for easier recognition, we change the colour of a scalpel, would that count as innovation? Well, it doesn't seem like major, it seems pretty small, but I'm colourblind. So depending on the person in the room, it could be major. And the third one will define continuous. Define what initiating change in clinical practice means. So we could have a trainee surgeon learning a new way of doing a technique that's established, but learns it from another surgeon and then starts to use it in their practice in a different location. That trainee surgeon doesn't seem to be innovating, but they seem to have met the conditions here. And it doesn't seem like that needs regulating in the same way as all other kinds of innovations. So we started some work on defining surgical innovation, and we thought, well, first of all, we want to differentiate between definitions and concepts. So a definition is always purposive. A definition is a characterization of a concept developed for a specific purpose, whereas a conceptualization is an attempt to draw together and capture the underpinnings of a concept that's divorced from any specific agenda. So definitions tend to be quite specific, conceptualizations might be quite wide. So we started with a conceptualization study, which has just been accepted for publication. And what this did is it did a systematic review of definitions of innovation in surgery and did a thematic analysis of all of these definitions to try to work out the elements of the concept of surgical innovation that were being used in the literature. And we came up with 5 themes that tended to be talked about a lot, not necessarily all together, but they came up. So the first was purpose. A definition of surgical innovation might pay attention to what's driving the innovation, what's the reason for it. It might pay attention to the place, and this might be both the geographical location or the context of the practice. Is it taking part in a clinical practice routinely, or is it in the context of research? A definition of surgical innovation might also look at the process. So is it an iterative process? Is it a one-off? Is it a step change? It might also look at the product, and this might be the innovation itself, a new technique, a new device. It might be the creation of risk and uncertainty. It might be a patent, for example. But definitions of innovation pay attention to the product. Then finally, and perhaps surprisingly, definitions of surgical innovation often pay attention to the person. They talk about the innovative character or the innovator surgeon, who almost by definition, what that innovator does is innovation because they are an innovator, which seems a bit circular to me. So I think there's problems with that, but it's there, so it's a theme. So we then tried to do we tried to work out a definition that was attentive to all of those elements of a concept. And what we found is that doing it in a way that avoids risk of false positives and false negatives is pretty much impossible. And I've not got time to take you through the process, but our conclusion was that the concept, or innovation as a concept, is cluttered with elements that are actually unhelpful, and at worst, actively obfuscating. They make it less clear. So we tried various working hypotheses of definitions, and they failed because they didn't capture practices we felt needed capturing, and did capture practices we thought didn't. And the most important feature, the reason that our attempts failed, was because they failed to capture the introduction of risk properly. So we were rejecting lots of definitions because it couldn't quite capture those practices that we thought were risky enough. And it tended to use proxies for risk, words like new, novel, untested, without actually dealing with that key point. So that led us to a conclusion that might be a bit revisionist, but we thought, well, why do we need surgical innovation at all? Why do we need that word? We've just spent a year trying to define it. Maybe that's a reason to keep it, but because innovation might not be necessary. So if our concern or our purpose is to facilitate the safe transition of surgical techniques and devices into practice, which was our concern, we don't need to talk about innovation. We just need to talk about safety and risk. So surgical innovation can be seen as just a term of art. It's a word that's used to refer to an ambiguous collection of practices that are loosely defined by newness, as a group in Australia captured quite usefully. But it's just a term of art. But it's not a necessary term of art when we're thinking about regulation and governance. So that's where we got to trying to define, and now communicating unknown risk. So our concern is with risk, and our concern is that techniques and devices may be being introduced into practice that may not be safe or effective, and there's just no governance or regulation of this. So regulation might help ensure that patients and surgeons can benefit from new devices, new techniques, but avoid the harms as far as possible. That's the point of good regulation. But the proper focus then is not on regulating innovative practice. It's on looking at and regulating changes that introduce uncertainty to the risk-benefit profile of the planned procedure. And the Newcastle case is quite a prime example of the robot. So whether what Mr. Nair did was innovative or not doesn't really matter. It doesn't matter if we label what he was doing as innovative or derivative or normal or standard. What matters is that in that time, in that place, for that surgeon and with that patient, the surgery that was planned had a very different risk-benefit profile to the standard procedure. There was a change in Mr. Nair's practice that introduced uncertainty and arguably made it high risk. So think about calculating, communicating, and consenting. When we're talking to patients and making that kind of assessment, calculating the precise risk-benefit that's developed when a change is introduced is challenging. There'll be a lot of uncertainty. And it's also fair to say that not all changes will introduce an uncertain risk-benefit, and it might be big or small, but any change has the potential to. So any change has to be looked at as a potential risk. And it's also true that not all changes to risk-benefit profile will be large or significant or important. But communicating risk that is uncertain makes consenting hard. And we know in consent, communication is key. And one of the big challenges with communicating about innovation is there is arguably a positive bias with the term. And this is, I suppose, an empirical claim we've not got evidence for. We will be doing this work to try and test it. But our hypothesis is that there is a positive bias. So people, when they hear this is an innovative treatment, what they hear is this is new, this is novel, this is good, this is beneficial. The term innovation is very thick. It's a rich concept. It's both descriptive and evaluative. We tend to mean we don't describe something as innovative unless we think it's also good. And patients hear that. So calling something innovative, we think arguably implies it's good and can lead to poor consent because it doesn't properly communicate the risk-benefit profile. And this is connected to the learning curve, because when we're thinking about the risk-benefit profile, the surgeon matters in a way that it doesn't matter for new drugs. So if a new drug is introduced or used, it doesn't matter who writes the prescription. It doesn't matter who gives it. It doesn't matter if it's the first time the prescriber's used it. The drug will either work or not work. But in any surgical procedure, it really does matter who the surgeon is. So we know that even established and known and practiced techniques can be performed well or poorly. And whether it's performed well or poorly will to a great extent depend on the surgeon's learning curve. Is it the first time they've performed it? Are they a surgeon trainer? Is it the first time they performed it without supervision? Did they have a second cup of coffee this morning? Did they sleep well last night? Yep. Who's holding the scalpel matters. And generally speaking, there is a literature, and it's unclear whether or not a surgeon has a duty to disclose their performance record to a patient. But arguably, when a surgeon is planning a change that adds uncertainty to the likely outcomes, and even just changes the risk profile benefit in a way that a patient would want to know when giving consent, arguably that should be communicated. It's not about performance record, it's about communicating uncertainty and risk. And this was certainly not done in the Newcastle case. So the surgeon was at the very start of his learning curve. He didn't have training, and he didn't disclose this to the patient. And the risk-benefit profile, because of that, because the technique and the device was new, because of his position on the learning curve, it introduced a very, very uncertain risk profile. So arguably what this starts to tell, I would say us, but me, and it'd be great if you came along with me on this, but what it tells me is that risk assessment seems to be more important than whether or not a practice is innovative. And dealing with this problem of risk and communicating risk doesn't require innovation. What it requires is an honest risk assessment by the surgeon, by the team, by the institution of the effects that a surgeon's learning curve might have on a practice. So if the focus is on safety and efficacy of this procedure being planned now at this time by this person in this place, it doesn't matter if it's established but the first time it's been used by the surgeon. It doesn't matter if it's brand new and it's never been done before. And it doesn't matter if the surgeon devised it and has done it 15 times but no one else has used it. All of these practices might or might not be classed as innovative, but it doesn't matter. What matters is the risk that's introduced. So saying this is the first time I'll be using this innovative procedure, even if you use the word innovation and you disclose your learning curve, that positive bias with the word innovation is not likely to clarify a patient's understanding. So this leads me, I think, to a hypothesis about the redundancy of innovation. Defining innovation isn't necessary, is the first claim. And instead, what we should focus on is asking these kinds of questions. To what extent an intervention presents a substantially new risk profile because of its difference? To what extent a risk profile can be anticipated because components of the intervention are tried and tested interventions? So if we know that this component is safe and this component is safe, can we anticipate the risks if we combine them? Sometimes we probably can, sometimes we probably can't. But it's about that risk assessment. And then what new risks might arise from any hitherto untried combination of these components? So if we're looking to regulate this kind of practice or stop this kind of death happening, regulation should focus on, first, assessing risk. It should focus on making sure there's appropriate methods for studying changes to surgical practice according to that risk assessment, and then also the appropriate reports of outcomes so that people can learn from mistakes and successes. So that's the first claim. The second claim is that innovation can actually be unhelpful. So it's not required, and because of the positive bias, it actually makes understanding less clear, or it can. A perhaps stronger claim is that the ambiguity of this term, the fact that innovation can mean many things to many people, leads to likelihood of equivocation. So people understanding the same, or using the same term but understanding it in different ways. So it can lead to misunderstanding, but it can also lead to willful avoidance of scrutiny. So certainly in the UK, if a surgeon says, I've got this new technique and I want to try it out, is it research? There's a lot of paperwork involved in that. No, it's innovation. And suddenly they don't need to go through all that paperwork. So there is a genuine advantage to the surgeon, perhaps, in terms of time, to not calling it research and to calling it innovation. So our focus should be on regulating the reporting and monitoring of planned or unplanned changes. And that's the key thing. So back to the case. Well, what went wrong? Well, probably lots and lots of things. It was a catalogue of errors, but key amongst them were the technology was new, the surgeon didn't have adequate training, and his learning curve was new. This combination of the newness and the point on the learning curve changed the risk-benefit profile, making it uncertain, if not certainly high risk, which I think it probably was. And the consenting process didn't adequately convey the risk-benefit profile. So key is that the risk assessment of the change to the surgeon's practice was inadequate, if it was undertaken at all. So could regulation help? Well, regulation might help. And I think in a conversation last night, I think it was you, Anna, you pointed out that, well, codes of conduct don't matter if everyone's determined to be bad, right? So regulation works if people care about it. No regulation can stop willful criminal or bad intent. So regulation could have helped if it focused on requirements to conduct and register risk assessments of planned changes to surgical practice. Regulating or relying on the regulation of innovation specifically, which is where the literature in UK is at. The language is all about regulating innovation. This may well have failed because the surgeon might not have identified what he was doing as innovation. So is it substantially new? Well, you'd think it would be, but someone else has done it before. So it's not new. It's new to me, but it's not substantially new. Is it major? Well, yeah, but it's still the same technique. It's just a robot's doing it, and I'm controlling the robot. So it's not substantially new. It's just a different tool. So there's lots and lots of ways that you can work around it, and it's that ambiguity that leads to the problem. So pinning or hinging regulation on a particular term is a problem. And the positive bias associated with innovation, which I don't have evidence for, but it seems very empirically plausible, might well impair consent. So the conclusion is that regulation for monitoring, evaluating, and reporting surgical practice should avoid the language of innovation. That's not to say the word should not be used at all. The word is used, it is there, it will continue to be used. But for the purposes of regulation and governance, it's not a helpful term. It should focus instead on what matters, which is simply changes to surgical practice that introduce uncertainties into the risk-benefit profile. And generally, this would require us to undertake and log a risk assessment prior to the procedure, report the outcomes, and evaluate the change. So there's going to be paperwork involved. And depending on the risk identified, there could be a range of regulatory responses. So it's not that everything is the same, it's that you have to do the risk assessment, work out what the risk-benefit profile is, and then it's regulated according to that. So everything is not just treated the same because it counts as innovation or not. So the point is that with this model, whether or not it's innovation is simply irrelevant. And I'll stop there. Thank you.
Thanks. That was really, really interesting and extremely helpful. I have a lot of questions. I'm just going to focus on one in particular. So I'm wondering whether you've thought at all about this sort of ship of Thebes kind of phenomenon in innovation. So you can imagine very sort of minor incremental alterations to a surgical procedure or to a device, et cetera, and this sort of steady kind of accretion that don't seem to sort of individually, each sort of, minor modification doesn't seem to add much uncertainty, but at the end of the day, you have a radically different set of manipulations compared with what you began. And it seems to me that, under the scheme that you're presenting, that might not necessarily be picked up in an innovation scheme because the scheme that you've described, because each incremental modification doesn't necessarily seem to confer any great uncertainty. But at the end of the day, you have what is kind of radically different. And it strikes me that my impression, I'm not an expert on surgery, certainly with devices it's the case that oftentimes that's sort of the way the innovative process works, these sort of very small changes that may accumulate a very different risk-benefit or uncertainty profile. So I just wonder if you have any thoughts about that.
Yeah, with devices, it's interesting. Of course, a device needs to be registered, but when a device is being marketed for, or when a small change is made, the developers will say to the patent office, this is massively different. This is innovation. It's different from standard devices in order to get the patent. As soon as it then goes to regulatory approvals, well, this is basically exactly the same.
Right, exactly. Yeah.
So, device, and I guess that's incremental issue in technique. I think I probably bite the bullet on it and say, well, that's the incremental development highlights the problem with hinging regulation on innovation. Because if we're looking to define innovation, it's difficult to capture that incremental change. So is innovation an incremental process? Is it a step change? Is it iterative? So those kind of minor changes won't be picked up as innovation either. I guess the point would be that surgeons routinely have variation in practice because there's a variation in physiology, for example. So they're good at adapting and changing. And minor adaptations, if they genuinely don't introduce an uncertain risk profile, if it's my wrist hurt the last time I did this technique, so I'm going to change the angle I hold my elbow at. That seems to be a variation that doesn't introduce massively uncertain risk, although it is a change in practice. If that incrementally led to standing the other side of the table or having someone else holding something while someone else put into, that could potentially count as a large innovation, but the way it was done didn't include any major uncertainties or additions or changes to the risk profile. So I think this model captures the fact that whenever a person is planning a change, you might get incremental changes that lead to massive change over time, but it's all about that change there at that point. And whether or not it's innovative or not, whether it's minor or major, if a risk assessment's done and it's decided that actually this doesn't introduce any uncertainty, then it will be okay on this model. And that is okay, I think, because our focus is not on whether or not we're capturing innovation. Our focus is on safety and efficacy. Also, I guess, the reporting would matter. Yeah. 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 So the point is that if you make a tiny incremental change at point A, that's then adopted for a little while, and then a tiny incremental change at B, and that's adopted for a little while, and then at C, that's adopted, and then the combination of incremental changes eventually leads to a completely new procedure at Z. That's theoretically possible. And I guess the point is that so long as those incremental changes don't introduce any substantial risk or uncertainty, then that wouldn't necessarily need to be governed in a particular way. It might still require reporting, but the focus is on what risk does this change introduce, and if it's so small that it doesn't need prospective permission for, but need reporting, then it's reported, but permission's not sought. And if that then leads eventually to an incremental large change, that's not necessarily a problem. What matters is the risk that's being introduced at this point. And I think this model deals with that better, because if we're concerned about hinging regulation on whether it counts as innovation, that incremental change won't count as innovation and so won't get picked up by regulation. If the focus is on any change that's introduced and a risk assessment of that, depending on the magnitude, different regulatory mechanisms might kick in. Does that clarify? Thank you.